Now let's discuss about something which is quite interesting in the emergency medicine, and let's see what it is. A 40-year-old female presents to the emergency department with an acute onset of shortness of breath for 10 hours. She complains of left-sided chest heaviness. Okay, so there is an acute shortness of breath, chest heaviness, and blood in the sputum prior to presentation. Her past history is positive for major depression, so she must be on some antidepressants, and for hypertension. She has been taking OCPs as well and has just returned to India from the United States when she experienced her symptoms. Oh, so immediately after the travel she had some symptoms. Now she has a pulse rate of 110, so there is slight tachycardia. The blood pressure look fine, and she has some amount of tachypnea. Okay, right. Okay, so whenever you see a patient with shortness of breath or chest pain, there should be some major differentials which should come to your mind. The following is not a life-threatening cause for shortness of breath. Acute coronary syndrome is, acute pulmonary embolism is, pneumothorax is, acute heart failure syndrome is. So the correct answer is acute cerebrovascular syndrome. This refers to a symptom complex of either TIA or stroke. Usually ischemic stroke. Okay, if any of them is present, these are classified as acute cerebrovascular syndrome. Acute coronary syndrome includes STEMI and non-ST elevation acute coronary syndrome, which includes NSTEMI or unstable angina. As per the guidelines, now these two are not considered to be separate entities, and they are thus grouped together as NSTE-ACS. So one is STEMI, another is NSTE-ACS. Okay. Pneumothorax, as you know, could be either spontaneous or traumatic. Spontaneous pneumothorax could be primary spontaneous pneumothorax or secondary spontaneous pneumothorax. Okay. Acute heart failure syndromes could be grouped into a lot of various subtypes and categories, which may not be important right now. Okay, so this patient has tachycardia, tachypnea, he's taking OCPs with hemopsis, shortness of breath and chest pain. This looks an interesting case. So let's see what the next question says. Which of the following is true? Looks like patient has a pulmonary embolism. Okay, OCP is a risk factor for development of pulmonary embolism. Tachycardia is common. Tachypnea is the most common sign of pulmonary embolism. Hemopsis is common. So there are a lot of things, and the patient had a recent long air travel. So the patient has a lot of risk factors for development of pulmonary embolism. So the Wells score is useful in prognosticating patients with pulmonary embolism related cardiac arrest? No, this is not a correct statement. Wells score is used for determining the pre-test probability of PE. So if the patient presents to you to the emergency department with symptoms or signs which are suggestive of pulmonary embolism, there would be various tests which a physician would employ. The utility of these tests for the diagnostic purpose would be determined by the pre-test probability using the Wells score. Okay, it's not used for prognostication. It's used for diagnosis of pre-test probability and the likelihood of diagnosis of pulmonary embolism. We'll see how it is further useful. Okay, troponin I has no diagnostic significance in the patient's condition, which is again a wrong statement. Troponin I, if it is positive, it is suggestive of submassive PE. If it is negative and the patient is stable, it is considered non-massive. So it does have some diagnostic significance in the patient's condition. Also, one of the differential diagnoses would be an acute coronary syndrome. for which troponin would again be an important diagnostic tool. Okay. D-dimer has a high positive predictive value for diagnostic pulmonary embolism. No, it's wrong again. The D-dimer has a high negative predictive value. Okay. So the D-dimer is very, very sensitive to rule out pulmonary embolism, but is non-specific. Hence, has a high negative predictive value. Majority of the patients with pulmonary embolism require just anticoagulation therapy. This is a correct statement. Let us discuss a bit about pulmonary embolism then. What are the categories and how do you go about treating pulmonary embolism? Okay. So, pulmonary embolism could be non-massive, submassive, and massive. So the massive PE refers to any pulmonary embolism with hypotension, bradycardia, or cardiac arrest. If any of them is present, then it is defined as massive PE. Submassive PE refers to a patient which does not have any features of massive but has right ventricular dysfunction. So the presence of RV dysfunction is diagnostic for submassive PE. This could be in the form of biomarkers or imaging, right? Non-massive PE, when none of them is present, no RV dysfunction and cardiovascularly stable. Okay, so the pulmonary embolism could be massive, in presence of hypotension, bradycardia and cardiac arrest, or cardiac arrest. Submassive, with no features suggest of massive, but there is evidence of RV dysfunction. Or it could be non-massive when both of them are not present. Okay. So what will you do if there is a patient who presents to you with signs and symptoms of PE which are non-specific? Now, you should always suspect. Whenever you suspect PE, you follow an algorithm. Random testing of using D-dimer and whatever CT scan or anything else would lead you astray. So whenever you come across a patient with like shortness of breath or chest pain or just hemoptysis, you should consider pulmonary embolism as one of the differentials. Look for the features which are suggestive of anything else like acute coronary syndrome, pulmonary edema, pneumonia, etc. And if they are not present, you should have pulmonary embolism at the back of your mind. Now, and usually the symptoms are non-specific, but still if you consider PE, you should use well scoring. Okay, and you dichotomize the patient. You may trichotomize, but you with modified well scoring, you use a dichotomous scoring. If the score is less than or equal to 4, and if the score is more than 4. If the score is less than or equal to 4, you use pulmonary embolism rule out criteria, which is a clinical criteria, and if the criteria is met, you don't have to go into the detail of what PERC is, but if the clinical criteria is met, you can clinically rule out pulmonary embolism and no further testing would be required. So if the PERC is met, no PE. But if the criteria is not met, you need to get a D-dimer. If D-dimer is negative, again there is no pulmonary embolism. If the D-dimer is positive, testing needs to be done. And the test of choice is CT, pulmonary angiography. This is the standard modality for diagnosis. However, if the score is more than 4, there is a high probability of pulmonary embolism and D-dimer is useless. You should directly go ahead and do the testing to confirm the diagnosis of pulmonary embolism, right? So, use a pretest probability, dichotomize the patient, and then consider the appropriate testing modality. This is how you approach a patient with suspected pulmonary embolism. Now, an easy way of remembering Wells score is DAMS tip. This is a mnemonic. D stands for evidence of DVT. A stands for alternate diagnosis, less likely. Okay, M stands for malignancy. S stands for sputum, that is hemopsis. T stands for tachycardia. I stands for immobilization more than 72 hours within 1 month. P stands for past history of DVT or pulmonary embolism. Okay, so this carries 3 points, 3.1, 1, and each of them, alternate diagnosis, less likely. Okay, so the rest of the three, 1.5, 1.5 points each. Okay, the total score you calculate. If it is more than 4, less than equal to 4. So more than 4, it's PE likely, PE less likely. That's how you approach a patient with Wells scoring, to do a Wells score. Okay, so keeping this premise in mind, let's consider what about the treatment modalities. Now once you have diagnosed pulmonary embolism, you classify it into non-massive, submassive and massive PE. Okay, let me change some colors here to tell you about the treatment modalities. For massive PE, you do thrombolysis. This is an absolute indication for thrombolysis. Okay, for non-massive PE, you use only anticoagulants. Submassive PE is a controversial area. Some patients with submassive PE receive thrombolysis. Some patients with submassive PE receive only anticoagulation. So there are various other treatment and decision points which you need to consider. But at this point, you just keep this in mind that massive PE with either hypotension, bradycardia or cardiac arrest. These are the only indications for, the only absolute indications for thrombolizing a patient with pulmonary embolism. And the drug of choice is TPA, which is FDA approved, and competent drug is tenecteplase. Okay, which has been shown promise in recent trials as well. Okay, so this is about PE. So majority of the patient pulmonary embolism require just anticoagulation. This is a correct statement, right? Very few of the patients are having massive PE requiring thrombolysis or submassive PE which qualify for getting a lytic agent or thrombolytic agent. Okay, so now we have seen the DVT, the Wells scoring. Now a patient has been diagnosed with DVT in the left femoral vein on color Doppler. A chest X-ray and ECG are non-specific. What is the Wells score of the patient? Okay, so now we consider the patient has, we write it down here. The patient has DVT. Alternate diagnosis is less likely. Yes. The patient does not have any malignancy. The patient has sputum with blood. Yes. Patient has tachycardia. No recent immobilization more than 72 hours. And no past history given on the clinical description. So the patient has 3, 1 and 1.5. This adds to 8.5. Okay, so the answer would be 8.5. So the well score of the patient is 8.5, right? Okay, come to the next question now. After 20 minutes, while the patient was wheeled back from the CT scanner. Okay, so 8.5 is a high probability. Next step would be to get a CT PA and to avoid getting a D-dimer done. Okay. So when the patient was being wheeled back from the CT scanner, she became confused and profoundly hypotensive. She was shifted to the resuscitation bay and started on fluids. A bedside echo revealed dilatation of RARV and McConnell sign. We'll discuss about it. The following is useful. Okay. So now the patient is hypotensive, right? This qualifies for this to be a massive PE. And the treatment of choice for massive PE, if you remember, is thrombolysis. Now let's go to the question. Infusing 3 to 4 liters fluid given fast. Okay. Sending a sample for troponin or NGAL. NGAL is neutrophil gelatinase associated lipocalin. This is a biomarker used for early diagnosis of acute kidney injury. It has nothing to do with pulmonary embolism so far. There is no evidence for its role in pulmonary embolism. Okay. Sending a sample for troponin and NGAL. Troponin would be helpful because as we discussed previously, but this patient is already hypotensive. We don't need further troponin to diagnose a submassive PE when the patient is already having a massive PE. So this is wrong. Thrombolizing a patient's stat. This is the correct answer. Intubating the patient prior to any further resuscitation. No, this would be a wrong approach. Let me discuss why. Okay, so what happens in pulmonary embolism? Let me see if I've got that cardiac tamponade diagram. Yeah. Okay. So what happens in PE is that there is a pulmonary trunk. If it becomes a massive PE, there is a proximal impaction of the thrombus. This causes a back pressure change in right ventricle. When there is a back pressure change in right ventricle, this leads to dilatation of the right ventricle and eventually right atrium as compared to left ventricle. Okay, so there is an RV, RA dilatation. Because of the annular widening, there could be a tricuspid regurgitation. There is a tricuspid regurgitation as well. Okay, and there is something called as McConnell sign. All these features could be appreciated on a bedside echocardiography. And McConnell sign is there would be RV free wall hypokinesia. This wall would not be contracting properly with the sparing of the apex. Okay, so if you see contractility, RA will be large first of all. RV will be large, RA will be large. There would be a jet of tricuspid regurgitation, and the contractility wise, right ventricular wall would be hypokinetic, but the apex would be spared. So this is called as McConnell sign. So these are pathognomonic of submassive pulmonary embolism. That is because of RV strain. Okay. So in such a patient, if you intubate, what will it do is that intubation will cause intrathoracic pressure to rise because you are giving a positive pressure respiration. This will increase the RV afterload and will further increase the RV dysfunction. And patient can further collapse and develop hypotension and cardiac arrest. So this is not done. Similarly, if you infuse a lot of fluids, this will again increase the RV preload. And this will cause RV systolic or diastolic dysfunction again, right? So a lot of fluids are bad and intubation is bad upfront without hemodynamic management. Okay, so in a patient with massive P, so this is hypertensive massive P, you need to thrombolize the patient stat. Okay, so the answer would be thrombolysis. Okay, so this was about pulmonary embolism. Now we come to the next question. The next question, which is the following is not a contraindication to nitrate therapy. We have discussed this previously. So if the sildenafil citrate is used within 24 to 48 hours, this is a contraindication. Hypotension is a contraindication. Right ventricular myocardial infarction. So this is basically a preload dependent condition. And as we have seen, the preload dependent conditions are a contraindication. This is contraindication. Concomitant use of thrombolytic. This is not a contraindication. Okay, the nitrates can very well be used with thrombolytic drugs. Okay, what is a system's target to get an ECG done on a patient with ischemic sounding chest pain? Okay, so various guidelines have recommended a lot of systems goals. That's what they are called, the systems goals for approaching a patient with suspected coronary thrombosis or an acute coronary syndrome. For getting an ECG done, the goal is within 10 minutes. So a patient with concerning chest pain should get an ECG done within 10 minutes and should be interpreted as soon as possible by a physician. Okay, so the answer would be within 10 minutes. Now we come to the next question, which deals with the patient who is already intubated and crashes in front of you. Okay, so this is an asthmatic patient who presents to the emergency department with shortness of breath, likely an acute exacerbation. Was intubated in view of impending respiratory failure. So this patient really had a severe acute exacerbation. He was then started on further management of status asthmaticus. In some time, he started developing hypotension. Okay, so for whenever you consider a patient who is already put on ventilator and he deteriorates in the form of hypotension or hypoxia, worsening hypoxia, you should consider the mnemonic DOPES. Okay, D stand for tube dislodgement or displacement. O stands for obstruction. E stands for pneumothorax. E stands for equipment failure. S stands for stag breaths, also called as autopeep. Okay, so this is the mnemonic for any patient who deteriorates while on ventilator. Okay, so pneumothorax is a possibility. Yes, P, pneumothorax. First step shall be to disconnect the ventilator circuit from the patient. Okay, this sounds to be an absurd thing to do when the patient is already in the distress and the only source for the breath is a ventilator, but this is actually the right answer. I'll tell you why. The concept of stag breaths. Okay, if the patient is having significant bronchospasm, he is put on ventilator. The inspiration is active by the machine, but expiration again is passive. Right? But there is if there is significant bronchospasm, there would be less expired volume. Less expired volume. So what will happen is that more breath will go in as compared to coming out. So there will be stacking of breath. Right? This will eventually lead, if this becomes very severe, this will lead to increased intrathoracic pressure. So this would be, the extra air would be air would be trapped in the form of an increased intrathoracic pressure, thereby increasing the pressure and thereby causing hemodynamic compromise. May cause collapse, circulatory collapse. Okay. So how do you diagnose it? What you do is you just disconnect the ventilator. So what you do is that you disconnect the ventilator and look for a gush of air. If there was a gush of air, you diagnose stacked breath. Right? So it's as simple as that. What will this do? Gush of air will be there, stacked breath will, there will be decreased pressures, and there will be return of the original cardiovascular stability. Okay? So it's as simple as that. Just disconnect the ventilator. Here for a gush of air, stacked breath, if it is present, it will cause return of the cardiovascular stability. But if there is no gush, then you need to look for other causes as well. Okay? So pneumothorax is a possibility. First step shall be to disconnect the ventilator. That's correct. Patient may develop pulmonary embolism. And it is prudent to check the tube patency. Okay, so tube obstruction and the displacement are two important differentials. So this is okay. This is correct. Well, a pulmonary embolism can develop in a patient who is in ICU, ventilated for quite some time. But if the patient is in the emergency department who has been recently ventilated without any risk factors for pulmonary embolism and with a clear-cut diagnosis of asthma exacerbation, it is less likely that the pulmonary embolism will happen so fast in such a patient. So this is not the correct thing, and this is the right answer. Hello? Okay. Okay, so continuing the discussion after question number 37, where we left off last. Now we come to the next question. Here we have a 50-year-old male who presents to the emergency department with 2 episodes of hematemesis over 8 hours. Okay, so hematemesis means blood in the vomitus, which is quite suggestive of an upper GI bleeding. He has been taking frequent painkillers for his knee pain for last 5 years. He is a non-alcoholic and has no known comorbidities. He has a pulse rate of 120, which is quite high, and blood pressure of 110/80, which looks normal, and there is slight amount of tachypnea as well, which is the following is false. Okay, so considering the question and the case scenario, first of all, this patient presented with an upper GI bleed with a setting of an analgesic use for quite some time. Okay, so this suggests a kind of a peptic ulcer disease, which is possible because of analgesic abuse, or a situation of a gastritis, which again can present with an upper GI bleed. Now that is one thing, that this should be something which should be going on in the mind when you see such a patient in the emergency department, as to what could be the likely etiology, because the pharmacotherapy would change subsequently after the initial resuscitation. Having said that, the resuscitation, which is the most important part, in such a patient is common irrespective of the etiology, whether it is alcohol related bleed or a painkiller related bleed. The resuscitation part won't change and it remains the same. So you may wonder, why to resuscitate this patient? This patient's blood pressure looks fairly stable. He gives a history of painkiller abuse, and for his knee pain for last 5 years, looks like he has been talking and he is able to give the history properly. He gives his history of not taking alcohol or any other comorbidities as such, right? So the patient looks relatively stable on the first look. Not much of a tachypnea, slight amount of tachypnea is present, right? So you need to take you need to understand the hidden message that if you look directly at the blood pressure only, you may miss the patients who are unstable. Okay, so what you need to see is a combination of vital signs, that is pulse rate, blood pressure, respiratory rate, etc. Okay, so let me introduce a concept what is known as shock index. You must have heard about it previously, but let's see how exactly it works. Yeah, so just a second, I'll change a pen here. The shock index was brought into okay, before shock index, let us discuss something else about hematemesis. Hematemesis is basically exsanguination, a kind of hemorrhage which can lead to shock, right? So if you remember correctly from the trauma literature, there is an ATLS classification for hemorrhage. If it is a class 1 hemorrhage, class 2 hemorrhage, class 3 or a class 4 hemorrhage, depending on the severity. The severity increases from class 1 to class 4. Okay, so just to remember, it is like scoring in tennis, right? So if it is up to 15%, 15, 30, 45 and game over, right? So if it is less than 15, 15 to 30, 30, 35%, 45%, and if it is more than 45% blood loss. So this is how you define in the retrospect, if you can see the amount of blood loss. Depending on the amount of blood loss, there can be various responses. I'm not going into the details of the full ATLS classification and each parameter which is included therein, but important to consider is that hypotension develops only in stage 3 or class 3 shock. That is, systolic blood pressure falls here. There is some tachycardia here, nothing much. Okay, there is no change, no noticeable change would be appreciated in a class 1 hemorrhage in the patient's blood pressure values. In class 2, there is narrowing of pulse pressure. But systolic blood pressure remains strong. It does not fall. It's only in class 3 hemorrhage that you see a fall in systolic blood pressure, and in class 4 it's a frank shock. So this tells us an important thing is that if we rely only on systolic blood pressure, it is a problem. Another clue for amount of hemorrhage is tachycardia, but this is too non-specific. A simple anxiety or a patient who presents to a crowded emergency department itself may lead to a tachycardia-like state because of an anxiety. It could be a psychogenic cause. It could be because of fever. It could be because of any amount of pain. It could be because of trauma per se. Right? So it's a too non-specific thing to rely solely upon. However, tachycardia cannot be dismissed. So what is the solution? We come with a combination of these two things. That is blood pressure and heart rate, which would make it a bit more useful. So here comes the concept of shock index, which is having a normal value of less than 0.9. Some say it to range between 0.5 to 0.7 as well, but for all practical purposes, values less than 0.9 are considered to be normal. So how do you actually calculate it? So basically, heart rate divided by systolic blood pressure. So normally heart rate is low, systolic blood pressure is high, so the value is less than 0.9. As soon as the values start rising above 0.9, or 1, this should raise an alarm. Okay, this suggests that the patient may be having some amount of shock, initial shock. So this is again a physiological marker for cryptic shock or early shock. Okay, so any patient who presents to you with hematemesis, trauma, or any other potential condition which can lead to blood loss, look for vital signs, look for shock index for sure. It's very important. Shock index is very important. Also look for postural variation in blood pressures or heart rate. There is something called as orthostatic hypotension or tachycardia. So what exactly this does, how exactly is this done? We ask the patient to be supine, we measure the heart rate and blood pressure, then we ask the patient to stand up, and at 1 and 3 minutes we again take the heart rate and blood pressures. Okay. Now, how to remember what is a significant fall? If the blood pressure falls or a heart rate which rises after doing this, we call it orthostatic change. Okay. So there is rule of 10, 20, 30. If the systolic blood pressure falls by 20, diastolic blood pressure falls by 10, or a heart rate increases by 30. If any of them is present, we say that orthostatic signs are present in this patient. Again, this is one of the signs which, if present, should prompt towards a significant blood loss. Okay. So this is how you process your vitals, and do not just rely on static values which are provided by the monitor. Okay. So coming back to our patient, if we see, the patient is quite tachycardic. Though the blood pressure looks normal, if we calculate the shock index, it would come as 120 by 110, which is more than 1. Hence the patient is in early shock. Does he require resuscitation? Yes, he does require resuscitation. Okay, so considering this, which of the following statements is false? 2 wide bore IV cannula should be secured. That's a correct statement. For all patients who are in shock, early or frank, however is the scenario, you need to gain 2 wide bore. What is wide bore IV access? It's at least gray. At least gray. Okay. It could be bigger than gray, but at least a gray IV access should be there. 2 of such. So by wide bore you mean 16 gauge or higher. I mean 16 gauge or lower. In gauge it would be lower, and in diameter it would be higher. Okay, so at least 2. This is a correct statement. The patient is in hypovolemic shock. This is correct. Okay. As we've seen, the shock index is more than 1. So this is an early shock state. Hemorrhage control takes priority over fluid resuscitation. Well, this is something which needs discussion. We'll come to this again. Colloid resuscitation has significant advantage over crystalloid therapy. This is not a right statement. This is wrong. As we have previously discussed as well, for initial resuscitation, crystalloids are the fluids of choice. Colloid resuscitation has problems like, just to recapitulate, coagulopathy, renal failure, potential allergy, and of course cost. Right? So these are the problems with a patient who receives colloid therapy. And hence, the best, all of the three statements are correct except for this one, and hence this is the answer. Now, we need a bit of discussion about the third statement, that is hemorrhage control taking priority over fluid resuscitation. Okay, so this is a bit of a controversial statement. Ideally, if the option was to be framed, ideally it should be the fluid resuscitation is important, we don't have any doubt, but it does not take priority, till the hemorrhage control is done. That means you start off with fluid resuscitation, but you need to close the loop by hemorrhage control. And this is true for any kind of hemorrhage or hemorrhagic shock. Either it is trauma or a medical condition like the hematemesis, which we are discussing. So, resuscitation is very important. Without resuscitation, you won't have a live patient for considering hemorrhage control. But this should be used as a bridge to hemorrhage control, and this should not, resuscitation and over resuscitation, I would say over resuscitation should not be a priority. Over resuscitation should not be a priority and should not delay hemorrhage control. So hemorrhage control is an equally important step with resuscitation as the initial first step. Okay. So if we consider filling the tank, if we say that the intravascular volume is a tank, extra fluids which we are giving are a tap. Okay, so, and there is a hole which leads to hemorrhage, which empties the tank. By opening the tap, we are filling up the tank. By opening this or sealing this defect, we are closing the hole. Okay, so closing the hole is more important than filling the tank. Okay, this is to be understood. If we just keep on filling and pouring in fluids without closing this hole here, what we are going to do is to induce more problems to the patients. Okay, so we are not giving whole blood as such, and large amounts of whole blood anyways is mostly not available, or it's not feasible or practical to be given in the emergency department to a single patient. Okay, so we give crystalloids before we resort to blood products. If we give a lot of crystalloids, they cause dilution. They may lead to hypothermia. If you are giving cold, they may lead to further coagulopathy because we are diluting the coagulation factors and other cell products as well, and they obviously will lead to anemia, and they are not going to improve the overall patient's hemodynamics, the oxygen delivery part as well. Okay, so if we just pour in fluids without closing this hole, it's not going to help. So we need to close the hole or seal the hole along with opening the tap or filling the tank. Okay, so this is an important concept in all kinds of hemorrhages, including the trauma and other non-trauma scenarios. Okay. So, in a patient who has come with a hematemesis, that is upper GI bleed, how do we close that hole or seal that hole? Is by getting an upper GI endoscopy. As per recommendation, all the patients with hematemesis should receive an urgent upper GI endoscopy within 12 to 24 hours of arrival, especially if it is non-variceal upper GI bleed, if suspected non-variceal. If it is a suspected variceal upper GI bleed, it should be done stat. That is as soon as possible. Okay. Okay. Now we come to the next set of questions for which we have this clinical scenario. A 30-year-old type 1 diabetic male presents to the emergency department with epigastric pain and dyspnea for 6 to 8 hours. He has been vomiting frequently since then. The triage evaluation reveals a pulse rate of 120, a blood pressure of 80/60 and a respiratory rate of 30. He is fully conscious and apprehensive of his condition. Okay, so he's fully conscious, but he is apprehensive of his condition. You appreciate bilateral basal crepitations on auscultation. Okay, so this patient is a really sick one. Okay, so he is already having hypertension, he has tachycardia, he has tachypnea, he has some basal crepitations. So the lungs, the condition of the lungs is also not very good, though he is conscious, but he is apprehensive. So this apprehension could also be because of his hypoxia, could be because of his shock. We don't know exactly until we do the further examination and further evaluation of the patient. Okay, so he is presented, he is a type 1 diabetic who is presented with vomiting and abdominal pain. The first thing which comes to my mind when I see a patient with diabetes, type 1 diabetes, specifically type 1 diabetes, young type 1 diabetic, who presents epigastric vomiting and pain, is presence of DKA. And second thing which comes to my mind is an acute coronary syndrome. Okay, so you should not only look for chest pain in an ACS, you should consider acute coronary syndrome, that is myocardial infarction or unstable angina for that matter, in all patients who present with jaw to abdominal pain, which is above umbilicus. Okay, so this is, you should consider in all, especially if it is associated with vomiting. If you remember, okay, we'll be discussing it further later on. What could be the typical or high likelihood problems in a patient who presents with chest pain. Right. So as a sole resuscitator, what should be your first step? If you remember, we had discussed that there are two kinds of resuscitation: vertical resuscitation, if there is a single provider, and a horizontal resuscitation, if there is a team which can take care of A, B, C, Ds simultaneously. Okay. So for sole resuscitator, you have to go from A to B to C to D. Okay. So the first step would be for the management of this patient would obviously be airway. But as you can see, the patient is conscious and apprehensive. So airway looks patent. There is no obvious airway abnormality, which is evident from the scenario which has been provided in the question. Okay. So intubating the patient stat would not be the right answer. Coming to the next step would be the breathing. As we can see, the patient is tachypnic. This could very well be because of his DKA and acidosis, which is called Kussmaul's breathing. Right? These are rapid and deep breaths because of presence of acidosis in the blood. Okay? So this can also lead to tachypnea, but there are also some basal crepitations. So we cannot dismiss this tachypnea only to some presence of some acidosis. So there is also some primary lung abnormality which is going on. Okay? So next step would definitely be putting the patient on oxygen by face mask. Especially that would be especially helpful if we had a saturation SpO2 monitor attached and we could get a SO2 reading in this patient. But as you can see, the patient is hypotensive here. It may not be possible for the SpO2 monitor to catch the amount of saturation in the patient's peripheral blood, as the extremities could be cold and clammy. It is a possibility. Hence, we don't have to wait for an SpO2 to be recorded in such a patient with shock. It's prudent to consider oxygen, which is anyways not going to harm, but it would give a lot of benefit to the patient if the patient is already hypoxic. Okay. Getting an IV access is a part of circulation, and that should be done after the breathing has been taken care of. Assessing the blood sugar, yes, any patient who is apprehensive has some amount of alteration in sensorium. He is hyper alert. Even if the sensorium changes from normal alert to hyper alert, or from normal to drowsiness and to coma, in either direction, in whichever direction the sensorium shifts, it's prudent to do a blood glucose level. Okay, but that is the next step in D, and also this would be helpful in evaluating and managing a diabetic complication. Okay, so the answer for this question would be putting the patient on oxygen by face mask. That would be the first step, followed by getting an IV access, followed by assessing the blood sugar. And intubation, which is not right away required, may be required at a later stage depending on the patient's progression. Okay? Right. We come to the next segment now. After initial resuscitation, you gathered that the triage blood glucose, which was done in the triage area, was 450. You send necessary investigations but are told that due to technical problems, the electrolytes will not return in next 2 to 3 hours. What will you do next? Okay. So the patient is hyperglycemic. The patient is, I'll remove all this and see and consider again as far as the definitive management is concerned. Okay. The patient is hyperglycemic, which is a type 1 diabetic, epigastric pain, vomiting. Okay. Now since we don't have electrolytes and other blood gases available to us right away, we'll consider the presence of hyperglycemia. We treat empirically for DKA initially because the patient is tachypneic as well. So there's a problem. Okay. We have already resuscitated the patient, but now we need to start the treatment for DKA. But before we start the treatment right away, we need to consider a few things. For DKA, the first step is fluids. The treatment of choice to begin with is fluids and not insulin, mind you, it's not insulin. Followed by fluids, we need to consider insulin. But one of the problems before insulin, which we need to address, is the potassium. Because what happens is, because of osmotic diuresis and repeated vomitings, etc., the patient with DKA have potassium depletion. They don't have a lot of potassium in their body, but because of acidosis, it can drive some of the intracellular potassium outside into the extracellular space and into the intravascular compartment and can lead to hyperkalemia. So this is a tricky situation in patients with DKA. They have a total low potassium body content. Total body content of potassium is less, but they may have hyperkalemia because of severe acidosis. Now, even if there is no severe acidosis, or even if there is a severe acidosis for that matter, this is a fact. There is a total body potassium deficit. Now, if we start insulin in such patients, what will happen is that insulin causes internalization of potassium into the cells. It goes inside the cells and it causes hypokalemia. Okay. So, if we have not monitored the potassium values initially, this can cause life-threatening hypokalemia. And remember this, hypokalemia is the major killer after starting treatment in DKA. Okay, hypokalemia is a major killer. Before starting the treatment, because of the presence of severe acidosis, hyperkalemia is a major killer upfront. But once the treatment is started, once insulin plays into has come into the equation, then hypokalemia is the major killer. So we need to consider both hyper as well as hypokalemia. But as we have said that we have not got any facility for getting electrolytes for next 2-3 hours till the machine gets functional. Would you still give a bolus of insulin stat? No, you won't. You would not do that. Starting the treatment for hyperkalemia, this would be risky. As I said, it happens only if there is severe acidosis. Had there been no severe acidosis, more likely situation would be that the patient's potassium would be normal or the patients would having hypokalemia at the baseline. Okay? So if you start treatment for hyperkalemia, which includes insulin again, and including other things like beta agonists, which internalize the potassium into the cells, you can end up having hypokalemia, which could be quite severe and hence again life-threatening. So this is not the right thing. You will take a coffee break till the machine starts working. This is obviously a no-brainer. You will not do that. Obviously the patient is in distress, you have to treat the patient. The only option which is correct and is left is to get an ECG. How will it help? ECG has quite many features which are suggestive of either hyperkalemia or hypokalemia. It is important that one recognize the ECG features of hyperkalemia as well as hypokalemia. So let's discuss some of the ECG changes which would help you out. Okay, so you've excluded this, we excluded this. Answer is this, but let's understand the explanation for this. Okay. So for hyperkalemia is considered to be the syphilis of ECG. It can cause any change. Any abnormality on the ECG can be explained by some extent of hyperkalemia. So, however, typical findings would be a tall T wave, which would be pointy and at a narrow base. Okay, so it has a narrow base and a pointed head versus an hyperacute T wave, which is bulky and has a wide base. This is seen in MI. This is seen in hyperkalemia. Okay, so the next thing would be P waves flatten out. Okay, so if this was normal, it would look something like this. This is hyperkalemia. If this is normal, this is more suggestive of hyperkalemia. Okay. Other things would be widening of PR interval, QRS morphology becomes widened, and there is also a QT widening. So all of the intervals usually become wide and stretched out. It looks like if this is the ECG, someone has taken and stretched this ECG, it looks something like this. Okay, if you see something like this, it is bad. And the most dreaded thing is sine wave pattern, which is an extension of this abnormality itself. So you see sine waves like this. Okay, this is bad. Right, so these are some typical changes of hyperkalemia. Right, after this, if we discuss about hypokalemia, we have T wave flattening. We have prominent U waves. We have QT prolongation, but mind you, this is a pseudo QT prolongation, because what happens is that if this is normal, PQRST, PQRST, something of this kind happens in hypokalemia. This is a U wave with a flattened T wave. So the interval which you calculate is from starting of the QRS to end of the wave, which you would consider as T wave otherwise, right? So actually you are calculating a QU interval, but you interpret, or the machine interprets as a QT interval, and that looks widened. So there is a pseudo QT prolongation, and it can lead to further changes like ventricular tachycardia and other arrhythmias. Okay, so there are typical changes of hypokalemia and hyperkalemia in patients' ECG. It's prudent and see and look for any changes in the patient's ECG. Okay. Having said that, if there are no changes, no ECG changes, we could say that the patient is having a normal potassium values. We can, okay, so this is a very rough guide. No ECG changes does not mean that the patient's potassium is normal. He could still be hyperkalemic or still be hypokalemic. Okay, but it says that by and large, the patient does not have a life-threatening abnormality in the potassium levels. Okay, usually suggestive of a near normal potassium level. Okay, but you should understand that even normal serum levels of potassium does not mean that the total body potassium is normal. It still is a poor reflector of the total body potassium. Total body potassium of the body in patients with DK is definitely always low, right? So even if the potassium levels in the blood are normal, you need to supplement potassium. Potassium supplementation has to be given. Only and only if the patient is hyperkalemic, you do not give potassium. Otherwise, if the patient is having normal or hypokalemia, you give potassium. Okay, so this is an important concept to understand. If you recapitulate, hence you consider fluids. This is first thing. The next priority would be potassium, and the next priority would be starting insulin. Okay, so this is how you initiate a treatment in a patient with DKA. So first of all, you need to diagnose DKA. Only after that the treatment would start, right? Okay. Now, somehow the machine started working and the lab values are back. You found the potassium to be 4.2, right? And as we said, even normal potassium values should receive potassium infusion. Normal serum potassium does not mean that the patient is having a total normal potassium. Okay, so you administered fluids with KCl 30 milliequivalents. In 30 minutes, patient went into cardiac arrest, which on evaluation was related with hyperkalemia. So this is bad. Now, once I said that you should start potassium in normal serum potassium levels, and then you see an adverse effect. So there is something which we missed here. Okay, so one important history which we should take always at this point when we give potassium is urine output. If the patient is already having some kidney function problem or is having an acute kidney injury after some insult which precipitated DKA, what will happen is that kidney shutdown will be there, that is acute kidney injury would be there, and this is a situation which does not tolerate potassium load well, right? So we give routine potassium supplementation of 20 to 40 milliequivalents in this patient with potassium of 4.2. We give 30, but the patient has having an underlying acute kidney injury. This will cause precipitous rise in the potassium values and then can lead to cardiac arrest because of that. Okay, it's very important that we consider history of passing urine. When did the patient last pass urine? And another thing is that what is the status of the kidneys if the patient has any known kidney problem or is having any chronic kidney disease. Any of them is a very important historic feature before giving potassium. Okay, so this should not be missed. Okay, what about the history of myopathies? This is again important. Other things do not matter much, but history of myopathies is important not for the condition in DKA but for considering succinylcholine. While intubating a patient, if you remember, we use a paralytic agent. Two common paralytic agents are succinylcholine and rocuronium. There are n number of side effects and contraindications for succinylcholine, one of which is presence of myopathies. Okay, so if the patient has a myopathy, succinylcholine should be avoided and you should prefer rocuronium in such patients if you are considering intubation. This is not related to DKA in any way unless you are intubating a DKA patient, right? But since this was one of the options, it's prudent that we discuss it right away. Okay, right. So you start appropriate management of the DKA patient and the lab parameters show improvement over 1 to 2 hours. Although the patient keeps complaining of worsening epigastric pain and dyspnea. So if you remember, the patient had an initial dyspnea, which was an acute in onset again, with the simultaneous onset with pain, right? So you see a worsening of dyspnea and an increase in biobasal crepitations, right? So we are saying that was an appropriate management, so we don't ascribe this to fluid overload. This is not because of fluid overload, iatrogenically, right? So something else is going on. You got an ECG and found Deventer T waves. Now we'll discuss what Deventer T waves are in the chest leads. Okay, so again, the patient, you need to understand that DKA is not a disease in itself, not a complete disease in itself. It is it is kind of a physiological or pathophysiological condition which can be precipitated by n number of other things and which could themselves be life-threatening. Common of them are acute coronary syndrome, pulmonary embolism, stroke, surgery, any physiological stress like pregnancy. Okay. However, the most common of them are infection and non-compliance to insulin. Okay, so these two are the most common ones, but there are others as well. Of which acute coronary syndrome should always be considered as one of the differentials, right? So this patient has typical epigastric pain, dyspnea with features suggestive of heart failure here, right? So we suspect an ACS which is high in the differentials. Presence of bibasal crepitation would not go in favor of pulmonary embolism, so this is wrong, or this is actually ruled out, I would say. The patient does not have any neurological features, so stroke does not look likely. There is no history of recent surgery, and he is a male, so pregnancy is out of question. Non-compliance to insulin therapy is not on the differentials. Another important and very common cause is infection, which I mentioned. So the infection could be because of a chest infection. The source of infection could be chest, as the patient has basal crepitations. But that would not increase with ongoing treatment and ongoing therapy while the patient is in the emergency department. This is too fast a time course for a pathology to increase right away. And if it is a bilateral thing, that would make me a bit more, quite doubtful to make a diagnosis of infection in the chest right away. And I would still consider a pulmonary congestion or pulmonary edema, dynamic pulmonary edema, secondary to an ACS as one of the differentials and important life threat. So obvious next step would be to get an ECG done in the emergency, and there we see something which is known as Deventer T waves. The Deventer T waves are special kinds of hyperacute T waves. So these are hyperacute T waves seen in STEMI, or I would say these are STEMI precursors, because to diagnose STEMI you should have STE, that is ST elevation. But these hyperacute T waves precede the development of ST elevations, and hence are called STEMI precursors. What exactly are these? So a typical morphology of Deventer's T waves would be something like this. Okay, so this is P, this is an R of the QRS complex, there is an ST depression, then there is concave ST segment, and then there is a bulky tall T wave. This is typically seen in anterior leads. Okay, and this is suggestive of an acute LAD, left anterior descending artery occlusion. Okay, and if you follow up an ECG on this, you will see an anterior STEMI. So many times you will catch a patient in the emergency department on ECG with an anterior STEMI, but if he comes too early, within a few minutes to hours, then you may be lucky enough to find an hyperacute T wave with a Deventer's pattern here. That's what happened in this patient, and this is typical for acute LAD occlusion. Okay, right. So this patient eventually and subsequently had an acute coronary syndrome which precipitated a decay and had some amount of pulmonary edema because of pump failure. So whenever you diagnose decay, look for some other factors as well, because usually decay is just a part of the equation. It is not an isolated disease. Okay. Right. Having said that, inferior STEMI would be seen as an ST elevation in inferior leads. That is 2, 3 AVA. And we've discussed the ECG changes of hyperkalemia. So Deventer T waves is not a feature of that. Okay. Okay. Next to the we come to the next question now. Which of the following is not a major life threat during initial evaluation? Okay. So we need to consider about complications of DKA here. So let me enumerate the complications and we'll discuss some important complications of DKA. So one is disease related. Okay. Another is therapy related. So DKA is a double-edged sword. DKA is a double-edged sword. It has problems both related to the disease, and even if you start an appropriate therapy, if it goes inappropriate in some way, it can lead to some complications there as well. Okay. So important disease-related complications. First is, precipitating factor. If you just focus on the protocolized management of DKA without considering the precipitating factor, like an acute coronary syndrome, which our patient had in the previous question, we may miss a lot of things which can be done in the emergency department to save the patient's life, and despite the correct management of DKA, we'll miss and the patient can have a bad outcome. So we need to always consider this. As I previously mentioned, hyperkalemia, which is due to acidosis. If the patient has a severe acidosis, this can cause hyperkalemia, and this can be a life-threatening condition. Severe metabolic acidosis can eventually lead to respiratory fatigue and respiratory failure, but usually happens in severe DKA cases only. Profound dehydration can eventually lead to acute kidney injury. Severe dehydration can also precipitate deep venous thrombosis. So DKA patients are prone to develop DVT. They have a high risk for development of DVT. And obviously, if the infection was the precipitating cause, the patient can land up into a systemic inflammatory response kind of situation and sepsis and subsequent septic shock, etc. Right? So these are important disease-related complications. Complications related with treatment are, first of all, those related with use of colloids, which I have previously already mentioned, includes kidney injury, coagulopathy, allergies. Second, if you give a lot of fluids, the patient can go into fluid overload state, which can manifest as pulmonary edema. Okay. Overzealous fluid treatment, especially in children, also leads to cerebral edema. This is an important and a life-threatening side effect, a therapy-related complication for DKA. Especially happens in young adults and children with the use of increased volumes of fluids, use of bicarbonate, and insulin boluses. All these lead to rapid change in osmolality and can lead to cerebral edema. Okay, so this is an important life threat which you need to consider. If you are not monitoring the patients properly, the patient can go into hypoglycemia, and which is an equally or rather a much more life-threatening situation as compared to just hyperglycemia. Okay, if there is no proper transition from intravenous insulin to subcutaneous insulin, if there is no proper transition, the patient can have a rebound and can re-land into decay. Okay, so these are some of the complications which are associated with the treatment of decay. Now, some of the major side effects, the major infections which are associated with decay, especially uncontrolled diabetics and decay, are worth mentioning, and they include mucormycosis, that is usually rhinocerebral mucormycosis, base of skull osteomyelitis, which is also called otitis externa, caused by Pseudomonas, a bad pneumonia, diabetic foot, emphysematous, pyelonephritis, acalculous cholecystitis. Okay, so these are some of the typical infections which are associated with decay or an uncontrolled diabetes for that matter in general. Okay, so these should be looked for and considered in all patients with decay if you are not able to find an obvious source or an obvious precipitating factor, right? Okay, we come to the next question now. No, so the answer for this: cerebral edema is a major life threat, acute coronary syndrome is a major life threat, hypokalemia. Yes, hypokalemia is a major life threat. I probably did not mention about therapy-related complications. Therapy-related, an important one is hypokalemia as well. Also, hyperkalemia, right? As we previously discussed. Hypomagnesemia is a known complication. This happens, but this is not important in the emergency department during initial evaluation and management, and usually is not a major life threat unless it is severe. So the best answer of the options given is hypomagnesemia. Okay, so we've been talking about decay for the last few questions, in which the K stands for diabetic ketoacidosis. So ketones, presence of ketone bodies is an important component for the diagnosis of DKA. So the predominant ketone body in DKA is beta hydroxybutyrate. So these three, beta hydroxybutyrate, acetoacetate and acetone, are the three important ketone bodies, of which beta hydroxybutyrate is the most common. Normally, beta hydroxybutyrate and acetoacetate happen in 1:1 ratio normally, but in DKA this ratio is tipped to favor more beta hydroxybutyrate, and it can be as high as 10:1 or even higher. Okay, so this is predominant, especially in the initial phases of DKA. But as the insulin treatment starts, the redox equation shifts towards increasing acetoacetate. Okay, so initially beta hydroxybutyrate predominates, and then with treatment acetoacetate increases. Okay, now the problem here, as I would say, the problem here with the diagnosis of these ketone bodies is the use of nitroprusside test as a urine dipstick. Now this very entity, the nitroprusside reagent, This detects only acetoacetate. Now, what happens if the patient has come to you with an early DKA? You get a urine sample and run a nitroprusside urine dipstick. Because the beta hydroxybutyrate is predominant and there is so less amount of acetoacetate, the urine dipstick may show negative or very low ketones. Right? On the other hand, as the treatment goes on, and if you keep monitoring the urine ketones may increase. Because the acetoacetate is increasing with treatment, the urine ketones may show an increase, which may give a false impression as to worsening DKA. But that is not the case scenario. Hence, it is recommended not to monitor ketones while treatment of DKA. They are of no use. Do not monitor ketones. Okay. We come to the next question, which is the following. With the reference to initiating the treatment of the DKA, what is the management priority? Fluids, insulin, potassium. I think we have discussed this in one of the previous questions as well. So if you can recall, the priority is fluids, that is X. These two are out. X followed by potassium followed by insulin. So it's X followed by Z followed by Y. So the answer is C. Okay. This is a very important thing whenever you start or consider starting the treatment for DKA. Now, this is an interesting option. All simultaneously, can we start everything simultaneously? We start fluids with potassium added and then start from the other line we start insulin. No, this is actually too aggressive. We need to go step by step, and unlike the early goal directed therapy in sepsis, which is aggressive, management of DKA has to be non-aggressive. Okay, so we don't have to rush. No rush, because more we rush, more fluids we give, more insulin we give, there is high risk for cerebral edema. So we do not want to rapidly change the internal milieu of osmolarity. We don't have to change the internal milieu of osmolarity, and to prevent the complications we need to be non-aggressive in treatment of DKA, right? So we don't have to aggressively manage a patient with DKA. Yes, initial resuscitation has to be quick, but once we start the treatment of DKA as such, disease-specific treatment, we have to be non-aggressive and we need to go step by step, right?